Okay, more small intestine pathology. This is an inflammatory bowel disease, very high yield topic. You're gonna get tested on this all the time. There's two of them. There's Crohn's disease and there's ulcerative colitis. Talk about Crohn's disease first. And the involvement here is this can involve anywhere along the GI tract from the mouth all the way to the anus. And what it is it's skip lesions, so it's just parts of it, various lesions all along the tract. The ileum is the most commonly involved, ileum in the small intestine. And then often the rectum is not involved, so there's rectal sparing. On gross appearance, when you look at the in the intestine or the GI tract in general, you're going to see transmural inflammation. So the whole wall is going to be inflamed. Okay, that's from the mucosa all the way to the serosa. It's inflammation. You're going to see cobblestoning. Okay, and you're also going to see creeping fat. There's usually fat like right around here that attaches to the small intestine, but in Crohn's disease, you're going to see creeping fat. It creeps all the way around. Okay. On microscopic appearance, there's a non-caseating granuloma. Okay, non-caseating granulomas in Crohn's disease. Clinical manifestations here. We talked about it. What were the questions we asked? There any malabsorption, any diarrhea, any bleeding? So yes, there's malabsorption. We'll get to that in a second. Is there diarrhea? Yes. There's inflammation. There's bleeding. Is there bleeding? Yes. Sometimes. Usually bleeding will occur if there's involvement of the colon. Okay, so there's diarrhea, there's inflammatory bowel disease, there's going to be diarrhea. If the colon is involved, you get bleeding. If it's not, sometimes you do, but usually you don't. And you almost always have abdominal pain here. Now, there's a lot of complications that can occur with both of these inflammatory bowel diseases. There's intestinal and there's extraintestinal complications. For intestinal complications, yes, I told you, both of them can have malabsorption. You can also have cancer, because cancer from that inflammation, irritation, causing mutations. Now, we have this transmural inflammation here. This is a key thing. It's transmural inflammation. So what's going to happen, what can happen is you can erode through this whole wall, and now you have a fistula. Okay, you have a connection between two sides of the small intestine. The other thing that can occur is you can have stricture formation. You can have all this transmural inflammation leading to fibrosis and a stricture. You have stricture in the small intestine, and then you can have basically obstructive symptoms of constipation, blah, blah, blah. So that's the intestinal complications, fistula, strictures. Extraintestinal complications, calcium oxalate stones. Now I'm going to explain how this happens. This is lower yield, and it's going to take a little bit of concentration to understand why it happens. If you want to just brute force memorize it, just kind of zone out, review what I just told you. But I'm going to explain it now. In the small intestine, we normally have calcium and we have oxalate. And these will bind together. Calcium will bind to oxalate, and they're going to form a little complex that will not be absorbed, and they're going to be excreted. Now in Crohn's disease, what happens is we have problem in the ileum. Remember that we said bile. What happens with bile in the ileum? Bile is recycled in the ileum. It's reabsorbed. If you have problems with reabsorption in the ileum, you're going to have extra bile. You're going to have decreased bile. And so now you're going to have a lot of lipids. Because remember, bile helps you absorb and emulsify lipids. So this lipids will form a complex with the calcium. It's going to form a soap complex. So now your calcium is not available to bind to that oxalate. Oxalate will be absorbed now because it's not forming a complex. And oxalate will be absorbed into the bloodstream, and then it's going to go into urine. And now you have oxalate in your urine, and oxalate is going to precipitate with whatever calcium is in your urine, and you're going to get stones. Let me repeat that. Normally, calcium binds to oxalate. They are excreted together. Crohn's disease, you can have involvement of the ileum. So if you have involvement in ileum, you have decreased bile reabsorption. Now you have increased lipids. Lipids binds to the calcium. Calcium is not available. So oxalate is now absorbed, goes to the urine, precipitates, causes stones in the kidney, and mainly the kidney. Now the other thing is that both Crohn's and ulcerative colitis will have rash, eye inflammation, oral ulcers, and arthritis. We're going to revisit that quickly in a second. Let's talk about ulcerative colitis a little bit more first, after we erase these pen markings. So the difference in ulcerative colitis is we have continuous lesions, and it's always starting in the rectum. So it always involves the rectum, and it can go backwards continuously and involve the colon as well. And on gross appearance, what you're going to see is, first of all, there's only submucosal inflammation. Okay, it's not transmural; it's only submucosal. You're going to have mucosal and submucosal. I'm sorry, but it doesn't involve the muscularis externa or the serosa. You can see pseudopolyps, as you can see in this picture here, which I misspelled. So little outpouchings, soft tissue outpouchings. And you have a lead pipe appearance because you lose the haustra. Normally you have these haustra here, these little like bendy lines, but you lose that, so now you get, it looks like a lead pipe. It's completely smooth. Okay. And then the other difference between Crohn's disease and ulcerative colitis is that there is no granuloma. I want to take a pause there, and I just want to emphasize that ulcerative colitis tells you a lot. It's inflammation of the colon here. Okay, starts in the rectum, can involve the colon, and it's ulcerative, so you can get ulcerations, which we saw in the gross picture. Now, clinical manifestations. What did I say about bleeding? When do we see bleeding? When the colon's involved, right? Well, pretty much the colon's always involved in ulcerative colitis, so it's almost always bloody. Okay, that's a big difference. If it's not bloody, it's not ulcerative colitis. This one may have abdominal pain as well. For intestinal complications, what are you going to see? Well, again, we said both this and Crohn's disease will have malabsorption and cancer. You can also see a toxic megacolon, basically a megadilation of the colon. Again, it's involvement of the colon, it becomes super dilated, and that's called a toxic megacolon. Extraintestinal complications. This one is associated with primary sclerosing cholangitis, which I'll talk about that later. It's basically damage to the bile ducts. You can also see PMCA. Ulcerative colitis is associated with primary sclerosing cholangitis, which is the destruction of the bile ducts. Now again, I said both can have rash, eye inflammation, oral ulcers, and arthritis. Visit the notes if you want to see more detail on that. I just want to say one thing. For the rash, it's going to be a pretty nasty rash, something called a Pyoderma Gangrenosum. Look, this nasty looking thing. So gangrenosum, so it's gangrenous. Pyoderma, so like pussy, gangrenosis, rash of the skin. So it's going to be pretty nasty and associated with both Crohn and ulcerative colitis. So again, there's a massive information here. It's pretty easy. It's easier though if you just compare and contrast, look at the pictures. The first aid has a nice mnemonic for Crohn's disease if you like. I liked it. And that's it. So that's it for inflammatory bowel disease.